health, fatigue, aging, and sometimes because a podcast host yelled mitochondria convincingly. So today we'll quickly compare creatine monohydrate versus the new kid on the block named creatine pyruvate, clarifying, of course, brain level dosing and even addressing the persistent and incorrect kidney myth that we always hear about creatine. So creatine monohydrate, 88% creatine by weight, near complete absorption with GI through the GI tract, gold standard with hundreds of RCTs, consistently saturates muscle and brain creatine stores. So the younger brother creatine pyruvate, the 60% only creatine and 40% pyruvate. So highly soluble, higher plasma levels, theoretically metabolic benefit via pyruvate and Krebs cycle insertion. So no evidence of superior tissue uptake or clinical outcomes versus monohydrate. Why I brought this up is because pyruvate has been claiming that is a better version of monohydrate. But we're going to look into literature here, and a majority of this literature will be coming, were cited from Jager et al. 2008, Carter et al. And Sports Nutrition 2017. But the bottom line here, monohydrate works because it gets into cells and stays there, and pyruvate looks good on paper, but not better on people. So most clinicians know muscle dosing for monohydrate is 3 to 5 grams per day. It maintains the saturation in the muscle. But brain creatine is different. Neurons have slower transport, lower baseline creatine, higher demand under stress, aging, and neurodegeneration. Studies have shown brain benefits at higher doses of 10 to 20 grams per day, used in mild TBI, depression, Parkinson's, and even cognitive fatigue. So this is Ray et al. 2003. This supports the improvement of working memory. Lyo et al. 2012, American Journal of Psychiatry, adjunct for major depression issues. And DeChant et al., American Journal of Physiology, 1999, brain uptake confirmed by MRS. So clinical pearl here is if the goal is cognition, neuroprotection, or anti-aging, 3 grams or 5, if you want that, is, I guess, underdosing the brain. So you need higher. So now the scary part here is the kidney myth. So let's say this clearly. Creatine does not cause kidney damage in healthy, all right, I want to emphasize that, healthy individuals. What it does cause is a rise in serum creatinine due to the conversion of creatine to creatinine. So which confuses clinicians who stop it unnecessarily when they see it on the blood test. And multiple large reviews confirms this safety. Paltman and Francois, Sports Medicine 2000, Gulano, Amino Acids 2012. So even in older adults, type 2 diabetes, long-term use up to 5 years, very safe. Exception though, avoid or monitor closely in advanced kidney disease, acute renal injury, and concurrent nephrotic drug intake. So creatine raises creatinine, not renal injury. So clinical takeaways here, monohydrate remains first line. Pyruvate offers no proven clinical advantage, but it's just expensive and it's easier to mix because it doesn't clump up. And brain benefits require higher dosing. Creatine is one of the safest metabolic therapies we have. If your patient is aging, sarcopenic, cognitively taxed, or metabolically fragile, creatine belongs in the conversation. So that's our tip of the week.
It was in the early 2000s that Mark McGuire was a baseball player, and it was found that he was using creatine, and it was kind of a scandal. I don't know if you know anything about that, or anybody. And
No, I haven't heard of that.
it caused muscle weakness and protein, and all sorts of issues with it. It was again another one of those knee-jerk reaction. Politicians were gonna get to the bottom of it. So, Stefan,
Right.
you know anything about that? Know anything about that from?
It does before my time, of course, Bill. You always have these stories that I
I'm
wasn't
old.
even
What do you
born
want from my
to.
life?
I wasn't even born to experience them. But I do have another pearl of wisdom. If you're ordering blood work on a guy who takes creatine or a woman who takes creatine, order the cystatin C. It's the best way to properly assess kidney function because you're gonna get your patient all worried that they have kidney failure otherwise.
Order what was it again?
It's called the cystatin C, Cystin C. It's about $40 with LabCorp, and you'll save yourself a referral to the nephrologist for a renal biopsy with an elevated creatinine when they're just taking creatine.
Okay, got it. Okay, since I've been living on the West Coast the last 12 years, my accent's changed. So I would have called it that when I was back home in Pennsylvania. So I got it now. Okay.
Okay.
All right. Um, so thank you very much. And Stefan, are you going to be hanging around at all? Because I want to, if you are, I want to ask you about your doctor, Jim. What's going on there? I got a message or something, and I'm kind of intrigued about
Oh
what
yeah,
you're doing. What are you
we
doing to
were
Dr. Klatz?
we were trying to fix them this weekend, and we made great progress in just 2 days. The doctors said they felt better than they had in months. Their brain clarity improved. They felt their life coming back to them.
In 2 days, but then they got to keep it up, right?
They got to keep it up. They can't fall off the wagon.
You gonna get a Beamer in shape?
Yeah.
Beamer, he also got into the cold plunge. He didn't partake in the rest of the protocol, but little steps with Beamer.
He was
I
more
know.
he was brave. He was braver than Halassa.
Better than Halassa. All three of them way better than Halassa.
All right. So Dr. Klatz is he's the big guy there. So you gotta fix him.
Yeah. And he said he got 20% better. I was on the call with him today. He said he feels 20% better today than he has in months.
And how is that measured?
He measured that by how he feels, his pain, his mobility, his brain, his speech, all of that. Yeah.
Okay. So Dr. Aunna, you getting the gist here of what goes on here. We've been doing this every Tuesday since 2020 in October. So last year, Christmas and New Year's was on Tuesday night. So Christmas Eve and New Year's Eve. So I skipped it. That was the only two we skipped, I think, in 5 years. So anyway, thank you for waiting patiently. So Dr. Aunna Herbst is authored Functional Medicine and Primary Care to help healthcare professionals incorporate personalized medicine into their practice. Her goal is to empower patients to be more active in their healthcare. Her mantra, I believe, root cause investigation for preventative wellness and chronic disease management is the future of medicine. Prior to medical school, Dr. Aunna was a business of lifestyle counselor. I'm going to explain what that is. Specializing in nutritional recommendations and naturopathic medicine. After residency, Dr. Herbst practiced family and functional medicine in rural America. Then she was one of the founding physicians at the Cleveland Clinic Center for Functional Medicine. Hey, do we get good speakers here or what? Huh? She's a proud mother of two, and they're very cute at that age. It said 29 and 26. I took it off your website. Is that dated at all? That's what it is? Okay. And she enjoys yoga, outdoor activities, such as kayaking and hiking. So the topic tonight is a cleaner, better you, biotransformation, detoxification. And so, Dr. Aunna, thank you for being here. You came from Dr. Cohen?
Yes.
Okay. All right. So thank you so much for being with us.
Thank you for having me. Can y'all hear me okay?
Yeah, it's a little bit of an echo. I don't know. I don't know if that's me or.
Is anybody else hearing the echo? I can't see slides. Have to hear yes and our screens.
It's a little bit.
A little bit, but go ahead.
It's okay.
Yeah, it'll be fine.
I'll try to talk over the echo if it sounds too crazy. There you go. All right.
You got it. Now you got it.
Okay, there we go. All right. So thank you guys. I thought the first of the year, everybody talks about detox, quote unquote detox. And I know that's for us medical providers, a little bit of a misnomer, maybe a cliche, trendy sort of catchphrase, but there is something to biotransformation. And I've used it in my practice over the last 20 years, on and off with patients in different scenarios. So I thought I'd broach this subject, hopefully shed some new information, maybe drum up some conversation. So basic objectives, I do what's called primary care functional medicine blend. I do a traditional primary care family practice board certification. That's my board certification. So we have the traditional family practice, but I have blended my naturopathic past and my functional medicine training. And now I do both in one practice with my team here. And so I think it's a little bit different. And I like to always talk about that a little bit because people always say, oh, you can't do both. There's no time in a traditional primary care. And I think actually you can do quite a bit. So that's a big passion of mine. Genomics is a real big part of my practice now. Started when they first did the mapping of genomes, and I do use it to help tailor my treatments for patients. Not all, but some, especially those that are really hard, that we kind of scratch our heads when they say they've been to 10 other quote unquote functional medicine providers or integrator providers. And, what are you going to do for me, doc? So those are the ones I like to use that with. We'll talk a little bit about toxins and what that means. Inside the body, outside the body. And I know a lot of you all are very well versed in this, so I'll try not to bore you. And then I'm going to wrap it up with a case example showing what I did and how I did it and, and outcomes following them with a, medical symptoms questionnaire and so forth and labs. So here we go. So the way, of course, if you don't know what functional medicine is, which I'm sure most of you do, I'll just make it real brief. It's looking at root cause, optimizing pathophysiology and genomics. Dr. Jeffrey Bland is kind of the grandfather of functional medicine. And he said, we're less concerned with looking at what we call dysfunction or disease. And functional medicine is more about dynamic process that resulted in the person's dysfunction in the first place. And so really the question is always why they present the way they present, what maybe is driving it, what started it, and how can we optimize that function. This whole pill for an ill thing is outdated. We need to start looking a little bit more for root cause, especially with our chronically ill patients. It's too costly. So I think that's where our medicine is going. It's, I think people are getting better outcomes. Providers are less burnout. And I think that's what's really driving that besides the patients and the consumer demands. My blended practice is history. I teach a lot of residents and students. That's one of the first things I have them, assess. And the patients often tell us what's wrong. They give us hints. So really listen, put your ears out, open your ears, take time to listen to their story and go through their entire history. I know a lot of providers that have a primary care practice don't have 30, 45 minutes with the patient, but you could have them write out their history. You can do a chronological timeline in chunks of 10 years and catch little clues of where things might have started going wrong. Maybe there's a hormone relationship, maybe there's a lifestyle relationship, something along those lines. So history is really important. Lab assessments, you want to reach for optimal. I assess labs, both traditional lab reference ranges, but also always trying to teach patients that, that's a big range and optimization is really the goal. Lifestyle modification is huge. I have a dietitian on staff, a health coach on staff, a couple actually, and I think that really helps us bring it home. If you don't have that available, you can still refer out to a good dietitian. So making that network, I think it's really important. We also have a personal trainer and a masseuse here on staff. So I have a lot going on, modalities for wellness care. A deep dive into specialty tests if needed. And I'll dive into some of those that I like to use. And then, of course, I do use medications. Patients will often come and say, I heard you're a naturopath, so you probably don't use herbs. I like to use both. I think they're good options. Herbal medicine and nutraceuticals change biochemistry just as medications do. If you understand the medication and the pathophys and the biomechanics behind it, then they're really powerful tools in your toolbox. So we shouldn't be afraid of them. We just need to know what we're prescribing. I always ask the question, why? Why the patient's sick? The one that's sitting in front of me, is it diet? Is it genetics? Is it sleep? If they're not sleeping well, obstructive sleep apnea, huge. What about toxins in the environment and internally? What about stress in their life? What about inflammation in general? Where's that coming from? What about gut health? And so there's a lot of questions we could be asking. If you don't have time to ask all of those or dive into those, I encourage providers just to pick one where they can capitalize on that. Sleep studies, powerful. If you're missing that, heart failure, right heart failure, all kinds of things going on with that, hypertension, et cetera. Common environmental toxins. People always think, well, what is a toxin? If you say detox, actually in the medical literature, you're referring to, coming off of a addictive substance. Biotransformation is the process of changing a toxin either made inside the body or brought in exogenously and converted through the liver or through a metabolic process. So that's actually biotransformation. That's actually the correct way of saying detoxification. But lay people like to say detox. They like to say, I want to detox my body, or I am going to go through detoxification. So there's a little misnomer there, but we use still and continue to use detox because that's how my patients talk. I'm from Arkansas here, and we just say it like it is. It's very simple. I don't make it complicated. I'm very down to earth. So We're talking detox tonight, aka biotransformation. There's a lot of environmental toxins. We'll talk about some of those and why they're important, but a common patient population that will present is this vague headache, chronic fatigue, fibromyalgia, the one that makes most of us in practice sometimes really challenged. And, they've not been heard, they've been pushed here and there, they've been punted from, one provider to the next. And unfortunately, that's sad for them, but those are these patients that I often think of. Why are they toxic? Could they be toxic? Is it started from something they were exposed to, not able to clear out? Why toxins? What are we talking about besides air pollution, soil pollution? They're important. It can be made in the body. It can be brought in from outside. We can talk about PFAs. We can talk about plastics, nanoplastics. But toxins basically are just something that's harmful to us. And this quote in the middle here from Augustine University really sums it up. While avoiding environmental toxins is completely difficult, it's very difficult, the awareness of their presence and their impacts on us can help improve public health. That's a very common sense statement. When people say, oh, what about toxins? It's very good to be aware. The more aware you are, the better decisions you make, but you can't live in a bubble. It's not possible. It's unrealistic, and it can create a lot of stress if that's what you're tiptoeing around and the way you're living. So I often educate them. We do our best. We educate ourselves, and we avoid the ones we can avoid. This is one of my favorite pictures. It's kind of hard to see, but the idea here is liver detoxification from aka biotransformation, changing something from a fat-soluble form, which is over there on the left-hand side, this toxin lipid-soluble form. Elected an assembly line, it's working its way to the intermediate metabolites, and this is like half polar, half non-polar, so fat, water-soluble-ish. And then it's got to be packaged into the water-soluble form so that it can be excreted, peed, poop, sweat, breathed out. If it is not able to do that, or if there's some sort of backup here in this conjugation section, phase 2, which a lot of people know about methylation, that's one of those pathways. If there's a backup here, I always tell my patients, if you're driving down the highway and you're going from 6 lanes to all of a sudden 2 lanes, you get a big backup, and some of those intermediate metabolites, the half water, half fat soluble, they got to go back through a process of back through the gut, back through the lymph, back to the bloodstream, back up again through, into the liver and try it again. That starts to be a burden on the system, and it'll really deplete some of these nutrients. Can she make them bigger? Oh, that's a good question. I don't know, Jenny. Let's see. Let me try this. I'm afraid if I do that, I'm going to mess it up. Hold on.
Yeah, I see 2 windows. Oh, there you go. Got it. Hey.
What's that?
Oh, you did have 2 windows, but it's bigger now. You can see it correctly now, I believe.
That was very muffled. Here, I'll go to the chat. Can you see it, Jenny? It's just small. When I release it, maybe you'll be able to see it better.
I can see it now. Wonderful. Thank you.
Oh, you're welcome. Okay. Now if I can, let me get out of this. That's funny. Now I can. Hilarious. Okay. Techie is not my strength. All right, there we go. I see Jenny. That's so funny. Okay, great. I see your name. Awesome. So this is a nice little visual that I share with my patients. I think it's really powerful because you can see the nutrients needed in this phase 1, which is most of your CYP or cytochrome P450 enzymatic processes. And then you get into these conjugation pathways where you're basically adding, maybe carbon and a few hydrogens and so forth. So methylation, glutathione pathways, your acetylation pathways, all of these are your phase 2. And that's really the big awesome part of detox. And so anyway, I use this as a visual to kind of talk to them about nutrients needed and so forth. We're going to talk a little bit more about that. Did it switch? There we go. These are the main ones needed for phase 1, phase 2, and phase 3 detox support. A lot of your B vitamins, most all of them actually required. Some of your milk thistle teas that can be powerful here, cruciferous vegetables and so forth. They offer a lot of phase 1 support. Phase 2 support, we're looking at things like glutathione and acetylcysteine, your amino acids like methionine and so forth. Calcium D-glucarate is a good one, actually. And that one's also one made and produced by gut bugs, bacteria in the gut. to help metabolize things like estrogens and so forth. And then, of course, there's a focus on phase 3 detoxification, and that's mostly in the GI tract. So really important to have, prebiotics, probiotic levels that are normal, no dysbiosis, because they're going to help us metabolize things and clear them out of the GI tract or recirculate as a healthier version of whatever that substance was and back into the body as it's needed. So really important. I like to point out the fact that the basic nutrients needed for detoxification boils down one more time to the root cause, to mitochondrial function. And if you look up basic nutrients needed for mitochondria, aka the Krebs cycle, like in this picture here, those are going to be the same things or very similar ones needed for your detoxification. So B1, B2, B3, glutathione, CoQ10 or ubiquinol, magnesium, iron, and so forth. So this is really powerful if you have a patient that comes in to see you and you want to do, like a GI support, or you want to give them a new medication, or you want to give them an antibiotic for an infection they have. If they don't have mitochondrial nutrients or detoxification capacity from a nutrient standpoint, you're setting them up for a real nasty detox process. They don't feel good. They come in and tell you they're allergic to the medicine, or they break out nasty hives all over. So really, if you can think about setting up the foundation for or prepping the body for any treatments that we're going to do, they have better outcomes and you have much more compliant patients because they actually feel good during the process. I never detox, quote unquote, detox or treat something major in a patient that comes in that is frail, that talks about being chemically sensitive to everything, perfumes, gasoline, medicines. They go through the list of allergies and my nurse is typing for 15 minutes. That's a big sign. We really need to go back down to root cause, clean up the system, give them back some nutrients, knowing that once they get better, I'm probably not going to need all of the nutrient support. But I do think it's important. It really gives them a better chance. They tend to do better with any supportive therapies. I also, when you get a complicated patient, I tend to look at genomics from a detoxification standpoint. It's really a powerful guide for me because if I suggest to someone, for instance, they lived over here in Oklahoma, there was a Superfund site. It was a really high heavy metal area. And so they come over to me and they've had headaches since they were in middle school, several family members with lymphoma. They've got this whole history. They can't stand perfumes. They can't be around smoke. They can't tolerate any medications. They hurt all the time. They're always tired. They dropped out of school, the whole messy mix. I always think about genomics. I think, well, maybe if they were exposed to a heavy metal environmental toxin, but they have a challenge with glutathione pathways, or they have a challenge clearing heavy metals, or they have a challenge with antioxidant production, decreased CoQ10 conversion, then they're already set up for, so to speak, failure. So I do think about genomics with my more complicated patients. I don't start out with all of them, but those I'm often thinking about because they've already been a bunch of places. They've already tried a bunch of things. I'm tired of the guessing game. It really helps direct my care. As an example here, if you can see, I don't know if you can see my pointers, but this GPX, GSTP, all the ones that start with G in here are very specific to glutathione, whether it's an enzyme pathway, metabolic pathway, or a true change, a compound pathway like a heavy metal. All of those are related to detoxification, heavy metals, pesticides, insecticides. This NQO1, for example, actually has to do with the ability to change your CoQ10 and vitamin E into their active forms. If a patient has one copy, their activity of that recycle, so optimizing vitamin E and utilizing E and CoQ10, which we know protects the muscle from breakdown, that reduces by 67% with just one variant, abnormal variant. If they have two copies or they're homozygous for this SNP in NQO1, they actually have decreased enzymatic activity for that recycle for CoQ10 and vitamin E up to 98%. So it's pretty significant. And they would feel a lot better if we gave them the bioavailable form of like ubiquinol, CoQ10, some support there. Maybe we give them a nice mixed vitamin E. So it's really powerful if we know that about them. That EPX that's on the list there is interesting because it actually has to do with the ability to clear aromatic type amines, so pesticides, dyes, diesel exhaust, tobacco, smoke, plastics. And so a lot of times people say, oh, I was really feeling good until I had breast implants, and I don't know what happened after that. Now I'm sensitive to everything. I start thinking about plastics and things like that. And so maybe they're an EPHX1 SNP type patient. This also is relative to mold toxin, like aflatoxin. So good studies on that with that EPX1. And we're going to talk about some mold toxins as far as some of our environments tonight with our patient. That ALDH one, not a fun one to know you have, because unfortunately it means that your ability to metabolize alcohol is really sucky. You have a greater buildup of this medium metabolite that's similar to formaldehyde, can be almost 13 to 16% more toxic than alcohol itself for these patients. But if they're sitting there drinking a glass or two of wine at night and they have this and they're wondering why they can't think in the morning or why they're getting sicker and sicker and sicker, this may be an answer. Not easy to suggest, not easy to remove for some people. So anyway, this is why it's important. GC here has to do with the main carrier for vitamin D. So if someone, says, yeah, I was on D for a while because it was really low, but it came back to normal and they told me to get off of it, or it was really high, so they told me to get off. Well, if they have trouble carrying vitamin D in and out of a cell because of this say they have a double variant here of this GC, they need to stay on that no matter what. You need to find the right dose for them. You can't just yank them off of it because they're going to fall back into that low vitamin D level again. So we do address gut issues when we talk about toxins. We also can get toxins from the gut. But if you hear the trendy word of leaky gut, I tell people this is intestinal hyperpermeability. In the medical literature, you're not going to find a whole lot of published literature that says leaky gut. But you can have intestinal permeability that just increases the body's ability to get things that shouldn't be crossed over into the vascular system or the lymph system, things that should stay in the GI tract and be removed and excreted out, sometimes can pass through into the bloodstream, causing our body to, what I call, mount a stranger danger response, inflammation, antibodies being produced, et cetera. So we start to get sensitive to things we shouldn't be getting sensitive to, or having abnormal reactions to things. So leaky gut is definitely a conversation we have, and we have all kinds of protocols for that. But it's important to think about when you're thinking about a really sickly patient. What's the gut health look like? Why it's important, because body can make endotoxins. These are going to be inside the cell wall toxins. These are weakly immunogenic, but they do mount a bit of an immune response. You have exotoxins that are actually from the proteins within the cell. Those are usually your gram positives and some gram negatives, but they definitely mount a strong immunogenic response. We're looking at things that, this is really bothering the immune system. And then, of course, you have your lipopolysaccharides. Those are going to be your outer membranes of bacteria, especially gram negatives. And there's actually pretty good literature and a lot of good recent studies where they're looking at the endotoxin LPS type toxins and their relationship to neurodegeneration. So this one here is talking a little bit about first in rats and then in humans, looking at the systemic inflammation and microglial activation with your endotoxins produced by H. pylori. And then also, they noticed that it increased endotoxin promoted amyloid beta plaque and tau aggregation. So really starting to say, well, wait a second, if the gut's not healthy, what's it doing for us from a neurodegenerative standpoint, Alzheimer's, Parkinson's, et cetera. So I do think it's important to address GI tract, but again, that's only one part of the picture. Just because I did functional medicine and alternative medicine doesn't mean I just treat gut first. I do it and I tailor it according to the patient. Or is our gut toxins and our guts making us fatter? There's a pretty good amount of literature that suggests this may be true. Some people have more of what's called white fat cells, which store more energy, and some people have brown fat cells, which use more energy and really interfere with our metabolic activity. That's kind of where all of our toxins are stored. Body likes to store toxins in fat tissue, so it's a nice little toxin warehouse. So when you get someone that is really toxic and they come to you and they say, man, I fasted for 40 days and I lost 5 pounds, but then I held on to this latter 40. I can't lose it. It's almost like the body, I tell them it's like the body's trying to protect you. If it dumps all that junk out and it doesn't have the capacity to clear it or metabolize it or get rid of it or keep you safe, then you could get really sick. Your brain is a large amount of fat, and so we definitely don't want it to go there, and it's wired to protect you. So I have a suspicion when they say things like that, that they're pretty toxic. Maybe need some help one way or another getting rid of things. Exogenous toxin, things like metals, mycotoxins from molds, chemicals, and so forth. There's a confusion about mold. Mold itself, the spores cause allergenic type reactions. They do not cause immunogenic type reactions. Mycotoxins, the actual toxins that are produced by the mold reacting with its environment, do cause immunotype and hormonal type disruptions. And so we'll talk a little bit about that because it's relative to my patient tonight. Heavy metals. I know this seems trendy. It seems annoying to a lot of my colleagues. They're like, oh, the person says they probably have heavy metals, and then they do a blood test and the blood test looks normal. Unless you're getting actively exposed to high dose heavy metal, it's not really going to be picked up in the blood test because that's more of an acute measurement, which is fine. And it's actually good to get a blood along with, if you're going to be looking at body burden, you could do provoke type test. There's not a lot of supportive literature saying, supported literature saying that we should be doing provoke test. It is just a measurement that gives me some direction sometimes to say how much the body's hanging on to. There's not a definitive reference range that I know of. If y'all know of one, that's awesome. I know there's a lot of discussion about what the reference ranges should be, but the problem is if you provoke and challenge someone and it binds to, say, heavy metals that are stored in the bone, like lead or fat tissue, and you catch it and you measure it in the urine, that reference range changes based on how much you gave them, what chelating agent you used, what their creatinine clearance was. And so there's a lot of variables, but it does give you a picture. If your provoke challenge test is extremely elevated in mercury or lead and their blood lead levels normal, but on the high normal range, okay, well, there's probably something going on there. Can it contribute? If you go back to that Krebs cycle picture, there are 4 or 5 places they've studied where it can really slow down and interfere with ATP production, several of these heavy metals. This picture here is taxi drivers because the study was done on taxi drivers, and what they were looking at is to see like how much heavy metal was in the blood of these taxi drivers, and they found them to be quite elevated, especially in cadmium, lead, and arsenic. What they looked at was inflammatory markers. So they looked at ILB1, they looked at interleukin-6. Both of those are genomic markers, and if you have trouble with interleukin-1 beta, or if you have an IL-6 SNP or double SNP, your inflammatory reaction to, say, a high blood level of lead could be off the charts. So they found these taxi drivers that had definitely elevated markers in those areas, as well as tumor necrosis factor alpha, which was interesting. You can measure those. You can also look at homocysteine. They found that the taxi drivers had much higher levels of hyperhomocystinemia. So that was interesting because we know that will affect, of course, heart and renal function. They also had low levels of glutathione. So again, going back to potentially, genetic mutations in the glutathione pathways, and maybe that makes it harder for them to clear this. Of course, that wasn't what their study was, but they just showed the homocysteine was higher, some elevated inflammatory markers, and glutathione lower in these taxi drivers that they looked at. And that was published back in 2016. So very interesting. Some of the interesting take-homes here on this slide. Arsenic, when you look at the symptoms of toxic levels of arsenic, you're looking at things like, of course, fatigue, because it interferes with ATP production, but eczema or allergic type dermatitis. You can get the white lines in the fingernails, some hair loss, some stomach issues, garlic-like breath. That would have to be a pretty good amount of arsenic, I would imagine. Your blood arsenic should be elevated also. But if you look at that slide, you can appreciate some of the genomic SNPs like the GST02, GST01, all of those can be tested now. And if they have impairment there and they potentially have arsenic exposure, aka they used to be construction workers and they used to put together deck work back in the 80s and 90s, that treated wood was loaded with arsenic, so potentially something there. Lead, you can see those, loss of appetite, etc., tremors, neuropathy. brain fog or lower IQ, cadmium, several different presentations, hypertension being one of them. Mercury is an interesting one. Metallic taste in the mouth. I used to hear people tell me that all the time, and I didn't know what that was for. And I have seen it be relative to mercury, but not all the time. Fatigue or lack of physical endurance, headaches, and a lot of numbness and tingling with mercury. So very interesting if we learn about that. Is it in our water? It's possible. Safe drinking water standards really haven't been established as far as radioactivity is concerned. And I see a lot of, unfortunately, radioactive like radon and rubidium and things like that on some of these provoked challenges that people will bring to me or that I have done in the past. And I was always curious whether that was really a bad thing or not. The literature says, low levels, it's not really harmful. We really don't know. A couple of big publications indicate that you could actually get exposed to this stuff downwind from fracking. So that way they were looking at these fracking wells. And I think it said if you were downwind, examine the increases in radioactivity of airborne particles when they were operating fracking wells within 20 kilometers upwind of a location. With 100 wells upwind, the average rise in radioactivity was 7%, but some places had nearly 600 wells upwind. So it's something that we're really looking into. There's not a lot of literature, not a lot of data. I don't think that we are as aware and as worried about it. I mean, we're worried about it now. We were not at the beginning. Radioactive tracers have not yet been listed on the Frac Focus, a website indicating chemical composition of fracking fluid. And so I think that's just a concern and something that we all need to be aware of. Sometimes you can get exposure up to 500, let me go back to that. Actually, you can get 10 times the recommended levels at 500 feet distance from a fracking well of benzene, toluene, and ethyltoluene. So we know those are not very friendly toxins. They looked at about 4,000 people that were not current smokers who lived about 50 kilometers from an air pollution monitoring station. And they found, and that was in northeastern United States, and they found that they calculated elevated levels of fibrinogen and interleukin-6 in these patients that they tested. And they were also noticed that they had, after they adjusted, of course, for the demographics and they took out smokers versus non-smokers, they also had elevated myeloperoxidase. So they're looking at things like, of course, that's clotting risk, stroke risk, et cetera. So something to be looking at, something to be aware of. So those are air pollutants. Mold. Hot topic, controversial topic. Man, I don't like this topic, to be honest. It creates a lot of angst in a patient. It creates a lot of life disturbance, and there's a lot of controversy around it. If you suggest to someone that they might have a mycotoxin challenge, the challenge is they go back and they tell somebody that they have a mold allergy, or they go see the doctor tests them for mold. They don't actually have mold allergies, and it's really not the same thing. What we're talking about is the toxins produced from the mold, not actually having a spore allergen or a spore ball growing in an organ. That's not what I'm referring to. I'm actually referring to the actual toxins. And those can elicit some immune or inflammatory responses. And some of them really depend on a couple of these genomic variants to help clear toxins via the brain and the gut. So they combined onto the toxin and they can help remove it from the body. Mycotoxins could be things like aflatoxins and so forth, studied mostly in animals, veterinarian literature from granaries and so forth. But they do elicit an ILB1, an MMP9, a TGF-beta response, increasing inflammation overall. And we do know that several of them are hormone dysregulators. So I think it's an important topic. I think that we need to support the body the best we can to help them. And the biggest and the most important thing is to get their environment that has the mold cleaned, remediated, and or get them out of it so they can get well. That's the number one treatment. Plastics, also a big topic. We know that the recent 2024 study showed that there were about 240,000 nanoplastic particles in about a liter of bottled water. 10 to 100 times more than they thought before. So that's a pretty significant eye-opener, I think. So plastics can be a lot of things and are found in a lot of things like the lining of cans, of course, water bottles, worse if they get exposed to extreme temperatures. And then also can be causes for of course, hormone dysregulation, diabetes, they know, neurological disorders, and cancers. So really something that we all should be aware of. And you can use the Environmental Working Group .org website to look at, better choices for, say, blankets or clothing or things without flame retardants, for example. You can start buying, bottles that are PVA free and so forth. Hormone disruption with plastics is really important to remember, especially when you're looking at young women, early puberty. We're talking about endometriosis. We're talking about fertility issues. I do think it's important. You can test for some of these toxins via the urine. And so if you're looking into specialty testing, not a bad idea, especially if you've done everything from, a traditional standpoint and the child or the young woman is still having heavy periods, can't get her PCOS under control. Glucose is very well regulated. You've done all the normal bells and whistles and tricks. You might think about toxins, especially plastics. Here are some little tips that I give to my patients. They can use this Environmental Working Group website. They can look for the Clean 15 or the Dirty Dozen so that you can, shop wisely. You don't have to buy everything organic. It's very costly. In rural America, that's not possible. But you could look on that Dirty Dozen list and you could say, okay, these are my 4 favorite things. I'm going to try to buy organic when I can of those. Otherwise, I'm going to make sure that I peel the peeling or clean it as best I can. So I think that's helpful. Trying to get into more clean bedding like bamboo or 100% cotton is always nice. Mattresses are a big source for off-gassing and a lot of toxic chemicals. Food with less ingredients. I do teach my patients that. Try to get something that has, 5 or less, or at least make sure you understand the lingo on the back when it comes to the ingredients. If you need a science class to read the ingredients, it's usually a bad thing. Put it back on the shelf is what I tell them. There is some literature talking about using modified citrus pectin. So, I don't want to get too woo-woo out there, but this one was really interesting. It was looking at a pediatric population of inpatient that had high levels of arsenic and lead and cadmium in the urine. And what they did is they gave them modified citrus pectin, and they gave them a pretty hefty dose, which I will say 15 grams is pretty common. But they did they used Pectisol, and they gave them 15 grams per day for 6 days total. With the last day, they gave them 20 grams. And on the first 24 hours, you can see there in the first 24 hours, they had a pretty significant drop. And at day 6, urinary excretion was increased significantly, especially for cadmium, which was 150%. And then, of course, lead showed a pretty dramatic increase in excretion of over 500% at that 6-day mark. So not a bad little tool to have in the toolbox. I will say with modified citrus pectin, if you haven't used it, if you start off at 15 grams a day, they're going to hate you because the bloating is unreal. So go really slow, baby steps, have them, work their way into it, and really watch those numbers fall down if you're doing tests and repeat tests. So real quick, if we have time, I'm looking at the time. Are we good? Yeah, we're good. Wrap up this case example pretty fast. I can't see faces, so I apologize. Hope everybody's still there. This case is a 27-year-old female. She had pretty much everything on the symptoms checklist checked. She had stomach issues, IBS-D. She's a really horrible menstrual cycle. She didn't sleep, sensitive to everything, couldn't take anything. Really wasn't trusting of me, has been to a lot of doctors and without much help. The reason she was really pushing her health quest is because she was trying and hoping to have a baby before she was 30. So that was her goal. This MSQ for us in my clinic, it's a multiple symptoms questionnaire. It's just a questionnaire we give the patient. We have them do it about every 3 or 4 months so they can kind of track their progress. It is subjective, but it's nice to see because sometimes they'll come in and say, I'm not better, but then they look and compare, oh yeah, I forgot I had that, or I forgot that. So it's nice. So I found some pertinent exam findings with her. She was a true fibromyalgia type tender point positive person. She had pretty significant lymph nodes in the anterior cervical region. She had an enlarged liver that was about, I'd say probably almost a centimeter or 2 below the rib cage line. tender as well, and her visceral fat was 13. And for us in my clinic, we like to keep that at least below 9, shooting for more like 7, 5, somewhere in that range. But visceral fat was high, and that's always the bad kind of fat. Her initial workup included a breath test. That's a small intestinal bacterial breath test and a comprehensive stool analysis because of her history of IBS-D. I did both, and the timeline we're trying to get her through a lot of this. So those are for interesting specialty type tests. We did the basic blood testing. There you can see the ones that I put that I thought were important to note. We did do a forever chemical test, which is a blood test you can get at Quest that looks at PFU and PFAs. She was a bottled water drinker, had been since high school. So I was just curious due to her fertility challenges, because that might be something we could target. We did do a heavy metal provoke challenge. She grew up in rural Arkansas on well water all of her life. And so that is something I tend to look for when their well water lived. And then we checked a mycotoxin antibody, IgM, IgG in the blood because she reported having exposure in college. So just checking to see what her levels look like now, see if she was sensitive. She did say her rental home had a crawl space, so that was also a reason we added to it. First initial lab review, a few months or a month or so later, I guess it was, progesterone to estrogen ratio on day 21. For me, that was not so awesome. I like that ideal ratio, definitely better than that. So for me, that was more of an estrogen dominant picture. Her thyroid also not so optimal. Her free T4 was okay at 0 or low normal, but 0.8. Her free T3 was low normal as well. Again, I shoot for optimal. Her reverse T3 was high at 23. And remember, that's your parking brake. It's trying to slow the body down when it's in a lot of stress or ill or whatever. So that's going to give these two guys put these two in a little bit more of a lower state. So if I could get the parking brake off, then I could get the accelerator going and she'd have a lot more energy. So I think that was something that we really targeted, try to slow the stress levels down, help her with cortisol, help her with sleep, etc. Liver enzymes are slightly elevated. I did end up getting an ultrasound on her with fatty liver. We also did a FIB4 test and she was an intermediate positive, so reason for ultrasound. Forever Chemical was in the moderate range as well, so not bad. But I think once we start cleaning up the system, giving her nutrients she needed, it'll probably come down without any major modifications other than quit drinking out of plastic and don't heat your stuff in the microwave in plastic. Vitamin D was great. I shoot for 50 to 70. Her phase 1 plan was pretty straightforward. We had her doing some limbic and vagal support, worked with the health coach on that. I suggested maybe some adaptogen teas, so forth. Remember, she's very non-trusting, so I was trying to be, not too esoteric and gentle and not give her too much to do. Really encouraging her normal sleep hours from 9 to 5, even if she laid there for a little bit, get up, but try to keep training on those hours. We did go ahead and start a combo of T4, T3, a low dose, 30 milligrams. Hoping that if I could turn the parking brake off with this stuff, the limbic, the vagal, the adaptogen teas, the adrenal support, the sleep, then she'd tolerate that. But sometimes if you give them a little active thyroid hormone and their parking brake's on really hard, they're going to call you back after day 3 and think it's not working anymore. I encouraged her to use the sauna. She tolerated hydrate, and no alcohol. I did order the liver ultrasound I talked about a minute ago. Her SIBO breath test was positive for the hydrogen at 87. That is significantly elevated. That required treatment. Beta-glucuronidase was positive and elevated in the large bowel, which really just tells me it's having a hard time typically detoxing, especially estrogens and so forth. Also a good reason for estrogen dominance. This Prevotella is a bug that actually is an autoimmune trigger, so it was interesting and it was important to make sure that we got some better homeostasis in the GI tract so we can dampen down some of our inflammatory stuff going on. Elastase was a little on the low, 123, did put her on prescription enzymes and PEP. And we did, of course, see fatty liver that was mild, reported on ultrasound. Followed that in a year. Phase 2, this was 2.5 or so months later. We were doing pancreatic enzymes with every meal. She did test for hypochlorhydria, and it was actually okay. She didn't have any trouble making her own stomach acid. Sometimes I see that in SIBO patients. I used Xifaxan, and I did use the low FODMAP when she was off of the Xifaxan treatment. I actually like them to sort of stimulate the gut bugs by eating a little bit of FODMAPs as they tolerate while they're on treatment, because I think that it hits it harder. Cruciferous vegetables introduction as able. We did start her on a DIM supplement to help with the methylation for the estrogens. And then we also gave her calcium D-glucarate, again, gut help for estrogen conversion and detoxification. And we talked about, of course, places where she could be getting some of those plastics. Oh, she was a LaCroix drinker. That's right. High PF use in LaCroix. And so we had her stop doing that. That was important. It was hard for her to stop, though. So we went a few more months. She did come back in and she said headaches and poor recovery were still pretty significant. And so we looked into more detailed testing. And so we did a nutrient panel. This is when we started thinking about heavy metal provoked for body burden challenge. And our antibody test came back. And I did that mostly because of the headaches in the house that had a crawl space and her past exposure of mold, known mold exposure. Of course, we're following thyroid and adjusting accordingly. Here's this is actually a picture of her mycotoxin antibodies. You can see some of these are pretty significant. She's got an antibody to Alterna. She's got an antibody that's up in the red to Cladosporidium. She's got one to Aspergillus toxins. And so it just tells me, okay, so we've got something going on either chronically or acutely. Look at the house, get a remediator, have them come in and test, do what you need to do. If they say it's bad, then get out. Her T3, T4 all look better. Reverse T3 is coming down. It's still pretty high. I like optimal less than 10, but it's definitely getting better. Vitamin D still really low at 28. Here we are, phase 3. This is all the way in January. So we're 6 months, 7 months into this process, and we've replaced nutrients based on our deficiencies. We started, she did get the mold inspection, so that's good. We started her on MCP powder to help with detoxification of heavy metals. Did not get a heavy metal test on it. It was too expensive, lots of things going on. So we just started MCP at low dose, 5 milligrams twice daily, just to kind of help maybe if there was something there. I was kind of empirically treating that. And of course, I now prescribe 20 minutes of a nap midday or rest, quiet time, no phone, and stimulation. We followed up in April. She was way better from a GI standpoint. No bloating, IBS was gone. She hadn't had headache in over a month, but she was still having them up until about March. So, improving, but still having them. Energy's getting better. She's able to exercise and recover. It doesn't take her 2 days to recover from a 20, 30-minute exercise or walk, which it was pretty challenging before. She did get a remediation person come out to the house, and they moved out because there was a significant amount of mold in the bedroom, in the closet, and so forth. Her menstrual cycle did return. It was getting more and more regular, but the key was it wasn't painful anymore. So it was still a little like 20, if I remember correctly, 25 days, sometimes 30, but it was getting better and not painful. So for her, that was a win. She was less sensitive to smells. She noticed that because they went to the mall and reported that she could tolerate candles when she couldn't before. So she did say, actually, I remember in April at this visit that she didn't feel all that fantastic. But when we did her MSQ, she was surprised to see how much it had changed from 89 down to 23. We followed these to be done later, just to kind of see tests of cure and so forth. So for her genomics finally came back. It takes a long time to come back. And she had these highlighted. So this one has to do with mold detox. This one is that CoQ10, vitamin E, recycle. This one has also some relation to mold detox. This one had to do with the alcohol. She didn't drink it regularly, but we did have her cut it out. Again, mold and gut stuff, vitamin D, and again, another one for glutathione. So that was my patient. And I always leave with this because this is my favorite saying. Thoughts become your words, words become your actions, actions become your habits, habits become your character, and your character becomes your destiny. Thanks for your time, guys. I appreciate your attention. Questions?
Hey, thank you so much. That was terrific. in our area, and I'm in northern Nevada, almost every every toxin panel, no matter whether it's urine, blood, or we even do hair analysis, comes back highly positive for uranium.
We
And
saw that a lot at Cleveland Clinic as well.
yeah, and what was, do you have any tips and tricks here? What to do?
Yeah, so interesting. And sadly, I don't have a lot of tricks because I'm not finding that a lot bind to it and clean it up. I do see it come back lower over time when people are actually detoxing or we're focusing, say, on lead or heavy metal. But when we were there, we actually talked to some of the environmental fellows about these numbers we were seeing in children, especially. And they claimed that low levels were not harmful. And yes, they do see that from the radioactive water they use in fracking. And so if you're in an area with fracking around you, it's probably coming from a water source. But there is nothing I know specifically that removes those radioactive type isotopes, unfortunately.
All right.
Anybody else? Mary?
You have any thoughts on what symptoms might develop from high uranium at all?
From the literature that I found, you can find some things like fatigue. You can see some lymphomas, but nothing specific that I know of.
There's a question in the chat. What was the reason not to drink sparkling water?
Oh, there were several that were shown to have pretty significant polyfluoroalkyls. So those are really powerful endocrine disruptors and weight gainers. And so the one that I remember specifically that was less toxic was the San Pellegrino. Am I saying that right? The green bottle. Anyway, don't drink much of it, but yeah, that's the reason why, just because of the polyfluoroalkyls.
Yeah, there's Pellegrino and then there's Perrier in the green bottle.
Perrier. That's it. Yeah, less of the bunch.
Okay.
Yeah. What else?
Okay, that's the only question. Anybody else have any questions in chat?
I have an email questions.
Fine.
All right, Dr. Aunna, that was a great presentation. So just to add to the uranium issue, EDTA, it's something that I have seen lower uranium levels.
What is it?
EDTA? EDTA, yeah, chelation.
Yes.
So that's something that we do here in the clinic. There is rectal form, and there's also in the market, they advertise oral form, but absorbability is very questionable with oral EDTA. So don't buy into that. I mean, our consumers out there, it's just rectal, or I mean, the most superior would be IV forms.
That's what I was saying. When I'm chelating them from a heavy metal standpoint, either EDTA or DMSA, we use both IV rectal and oral on the DMSA. We do see them come down, but I can't find literature that says it actually brings it down. Anecdotally, I see it as well. So thanks for validating that, because I think, well, maybe it's just me, I don't know what's causing it. But yeah, thank you.
Yeah. So here's a question for you. So in the genetic part of your presentation, so I have my favorites for genetics, ApoE especially for assessment for Alzheimer's, dementia. As we all know, that's the transporter of our cholesterol and triglycerides in relation to the LDL receptor. And ApoE4 is something that we always look out for in relation to higher risks of these Alzheimer's and cognitive diseases and pathologies. So what are your thoughts with this statement that genetics are always going to be dependent around the environment that they live in? Basically, they're describing epigenetics here. And knowing the genetics right now, does it really bring much to the table in relation to your clinical use in your practice?
Yeah,
so epigenetics.
Yeah, epigenetics, absolutely. So genetics are mutations, deletions that are pretty well fixed. Genomics have to do with the way our genes interact with the environment. So we are able to influence whether it's an environmental exposure, something we take, meditation, deep breathing, sleep, etc. So that's the epigenetic component. ApoE, for example, when you look at ApoE4 just by itself, it doesn't really mean you're going to have Alzheimer's. It needs, it needs a TOM40, which is the mitochondrial component that gets all gunked up, and then that sort of turns on and gets it going. It needs an ApoC1 to flip the switch for ApoE4. So there's a lot of components to it. But I do use them as tools, and it really is empowering to patients to know, hey, I've got a few of these. These are some lifestyle things I can do. These are some nutraceuticals I can do that could help keep these from getting flipped on, etc. So yeah, I do use them very much so, more as motivating factors than anything.
So out of my own curiosity, so every patient of yours goes through genetic testing?
Yeah.
Is that how you do it? Okay. How do you select?
Cost usually is probably the big prohibitor. I use it for the ones that have guessed a ton. We can't figure out what's wrong. So it kind of gives me more information. People that have been really, really ill, or people that can afford and are really interested in preventive. You know, they have a parent that has Alzheimer's, or they have diabetes history, or they have a stroke history, and they want to know, you know, what can I do and what does it look like? And that's when I use it. But I'd say probably about 40% of my patients have done genomics. We have a panel of 2,000-ish patients.
Hey, usually the hindrance there really is the price. If you could just do it on everybody, right? That would be your cheat sheet through your whole consult right there.
Absolutely. Absolutely.
Yeah, so let's ask our sponsors to give us discounts for this. So another question would be, so you showed a slide there about mold, especially, you know, there are so many protocols out there. You mentioned MMP9, TGF-beta1 there. That usually falls in the umbrella of the shoemaker protocol. But in your realm, what protocol do you favor, and what the most effective one that you've used in your patient population?
So the funny thing about that is, when I was at Cleveland Clinic, my job was to write the protocol. And of course, everything that we did had to have literature support what we were suggesting. And so I interviewed Shoemaker, Neil Nathan, and Sheppy, tried to bring it all together and make a protocol that fit. I found it to be very intriguing. The lab testing that Shoemaker did, he was way ahead of his thinking and his time, but I couldn't find any validity or specificity to say, oh, this is directly tied to mold exposure in a lot of his tests. And so I had to piece it all together. So my protocol is actually a hodgepodge of a bunch of very smart people, not me. I put it all together.
Hey, you're the smart one. You got them all together.
Yeah, so that is my protocol. It's everybody's good pieces, and then I learned from them.
So we have a resident mold expert here. You didn't mention his name, Dr. Andrew Campbell. Was that something also part of
He's amazing.
The slew of experts that you researched
Absolutely. He's actually teaching me in the last conference I was at. He was spending enough time to educate me a little more on his testing. So fantastic. When I was back at Cleveland Clinic, that was his testing actually wasn't even available. The blood test that he has now, Dr. Campbell. So I've now incorporated that into it as well.
Yeah, that's the test that you showed, I think, for one of your patients.
Yep.
Dr. Bell, you were about to say something. Go ahead.
I try to pin Dr. Campbell down, and I never get a straight answer. But so he's got a list of 14 mycotoxins. And I always forget, is it IgG? And then he's got an IgE.
Yeah.
Says his mast cell. And do you tailor the treatment for each one of those mycotoxins, or is it just one size fits all? I mean, he likes itraconazole for everybody.
It's a blend. The amount of years I've done it, I noticed that nobody really fits one thing. And so it's so humbling. But I do think a big part of it is supporting the system in the first place. If we have a fairly homeostatic system and you get them out of the moldy environment, then you step back and say, what's left and how can I support it? You know, do they need something powerful like itraconazole and see if it helps empirically? Do they need binders? There's no proof that binders work except in the veterinarian literature. So yeah, I know they're not a pig or a rabbit or a dog, but at this point, would it hurt to try a little activated charcoal here and there? So yeah, I really tailor it to each person, and it makes me sound like I'm completely ignorant, but I feel like I take from all of those wise people and I apply it to the person that's sitting in front of me. So yeah.
Dr. Siegel isn't on tonight, huh? Dr. Campbell says binders aren't, there's no literature on binders and don't use them. Right?
He does not like them. Exactly.
No literature on doing urine tests and don't rely on them either.
Right, exactly. I've heard it from all of them. I heard Shoemaker's side. I spent hours with him. I spent hours with Neil Nathan. I got it all. And then I sat in front of the infectious disease and environmental guys, and they're like, "Oh, it's all crap." So I got all of it.
Well, good thing you didn't put them all together in one place. They're all going to be doing fisticuffs at each other.
Well, if you ever could imagine Neil Nathan, if you don't know him, if you've ever met him and Shoemaker together, that was an interesting meeting.
Oh, I've heard. I
think to see and Campbell together. They probably
yeah, him too. Add him in the mix.
Also smart, so smart, really brilliant people. And I think we could glean a lot from them. And I think, unfortunately, like any of us, if we get locked into one thing, we miss some of the important information that someone else may have, gathered or gleaned. So I think that's the biggest challenge.
So one of my curiosities out of your testing, the forever chemical test. I haven't done this.
Mm-hmm.
Is this covered by insurance, number one? And then number two, I mean, other than avoidance, of course, of the plastics or where the sources would be, what are your interventions for the test that is positive that would come out from this?
Yeah, actually, there are some. So I base a lot of my interventions or support on genomics if I have it. Otherwise, I just say, generically speaking, glutathione support, your conjugation pathway support, your liver detox pathway support from a nutrient standpoint. I haven't ever seen insurance pay. I have tried coding it with environmental exposure, adverse reaction to foods and things like that, but I haven't got an insurance pay. If somebody else has, that'd be great. Tell me what you're using because my patients would love that. But no, unfortunately, it's about $300 from what I remember.
And you're using detox supplements from the sound of it, glutathione, right?
Mm-hmm, mm-hmm, mm-hmm. Yeah, and then of course massage, lymph stuff, dry brush, sweating as much as we can get them, exercising, lots of hydration. Yeah.
And how long do you see the number go down? I'm sure you recheck that, or you don't.
Yeah, in about 12 weeks, I typically will recheck. And I will tell you what I see first. In women, I see hormones start to balance that before I even check. Like I actually see, oh yeah, my periods are better, or I'm losing weight. You get the female that's gaining weight. They try everything. They're eating right. They're doing insulin's fine. Glucose is fine. They're like, you can't, you're scratching your head. Start cleaning up their environment, those sorts of things. A lady that I had, they were spraying for ants 3 or 4 times. The daughter gained like 10 pounds. And we were like, what? Come to find out, she's very sensitive to that stuff, pesticides, insecticides, so forth. And so for her, just supporting the system, helping her clean it up, getting it out of the environment seemed to help.
So it was not the burger that she was eating. It was more of this ant spray.
So I always challenge that because they're like, no, I eat really healthy. But yep, slap a glucose monitor, have her meet with a dietitian every week, have a log, and you go, okay, well, even if you're cheating, it's not that much. Like that's not it. So that's when you do. But you're right. Always question.
Never the burger. It's never the burger.
Never the burger. Or the Starbucks, 500 calorie sweet drink in the morning.
Yeah. And so I've heard a lot of and I've seen modified citrus pectin as one of like the wonder supplement out there, especially now the rise of galectin-3. And I don't know if you heard of the product TB006.
Oh no.
So that's kind of like one of the hotter items in A4M recently. It's to lower down galectin-3 in the brain that actually has been rooted to cause even dementia or Alzheimer's. So it's an infusion. But anyway, where I'm going with this is MCP is actually made to lower down galectin-3 by Dr. Elias. Yep. And as you have cited a study here, cadmium, arsenic, and lead. Are there other things that you have noted in your practice that MCP lowers down other than these specific heavy metals, or they're just specific to this?
No, I often use it for heavy metals, just empirically, but I also use it for this plastics and the forever chemicals. To me, it acts like a little magnet binder for crap.
Right.
That's how I'm using it. But I also see my cystatin C and my galectin-3 numbers getting better when I do those on my longevity panels. So
Right.
patients that have EGFR that's low, they're showing signs of maybe lower kidney function, I suggest it.
Right, right. I have smart patients telling me that MCP is actually peelings of oranges and apples. So it's a little bit of expensive in terms if you buy it. But if they tell me I'm just gonna eat the peelings, go ahead, eat it if you can tolerate it.
If you
So
can eat that much, I always tell them, okay,
I
that's cool. You
know.
probably need about 30 to equal your
Right,
15
right,
grams.
right.
Good luck.
Yeah, but that is the source for everybody who doesn't know that's where it comes from. So, but get the pill, save
Yep.
yourself all the hassle.
Yep.
Okay, Petronella, you have a question. Go ahead.
Oh, yes, I want to say, I want to add something that I know. I know that there are studies published that it also decreases the mercury, modifies cytospectin. And I know that it's a doctor, Dr. Chosky. I take a class with him on Thursday about redux and ASEA water, and he gives ASEA to patients, and he did a panel. He used Vibrant lab. He uses Vibrant, and so all the metals, all the PFAS, everything went down significantly
Oh,
uh,
wow.
after with ASEA. And actually, he wants to come to, maybe he can present one time. He's very interesting. He's very good. He's also very good. And um, so I know this, and at another conference they talk about plasmapheresis also
Mhm.
removes all the um, plastics and everything. It has to be done though 5 times because it always the toxins from the tissue they mobilize back in the blood, and so we have to clean multiple times the blood, about 5 times to clean everything. And then cognition improves by 40% with plasmapheresis. And
Right.
it's a easy procedure. I saw it video when it was presented to us, and it's about 45 minutes, one session of
It used to
plasmapheresis.
be really expensive. Is it Petronella? Is it expensive now? Used to be very expensive.
It is expensive, but the procedure itself, it's not complicated.
Yeah.
It's
Complicated, but
expensive because the machine it's about $100,000, and then I think the kit there it's a kit that it's used for each patient, and then I do not know the price, whatever it's. I do not know how much is the kit. I also know Ibu. We were told Ibu. Some doctors they give EDTA and they do Ibu, and metals drop significantly. Like you have to do a lot of EDTA sessions because for EDTA, when I took a class in chelation, they told us you have to do for 33 times at least, 3 grams over 3 hours. So to decrease all the heavy metals.
I
And
think the price for the
over the
yeah,
years, I actually haven't found it to need that much. Yeah.
not that much.
No, it just personally in practice, I've been doing EDTA IV probably total of 12, 15 years or so. I haven't found that you actually need as much as I was taught also is what I was saying. I was taught you need a lot and for a long time. And I really truly am not seeing that. But I'm sure it depends on the load. I'm sure it depends on the patient, et cetera. But I feel like it's probably a little bit much. Now, do I think they need ongoing maintenance? A lot of times, yes. Here and there. Yeah. But anyway, that's just what I've noticed. Not as much. Yeah.
I heard from a
Yeah,
patient they were charged for I guess plasmapheresis for $5,000. I
Okay.
think that's I mean they package it up too if you get two, three
Yeah.
treatments, of course it goes down, but that's a single therapy, as I've
one
heard.
one therapy is $5,000. But I heard that Dr. Halasano is that much cheaper, I think.
Dr. Bill. I think Dr. Bill knows that.
The theory would be it would clean out for the moment, but isn't that a temporary, like if you can't detox in general and you get exposed environmentally, yes, symptoms get better for a period of time. So you basically would know that if that worked well for you clinically, in theory, you would expect that once a year I got to go for my little, plasma exchange and then I got to do it again. I would think in theory, I don't know. I'm not versed in it. I was just more asking, do you think that's how that would work, or is it a one and done?
Definitely not. I agree with you, as you mentioned about your genetic SNPs, right?
Yeah, that's what I was thinking.
Yeah, everybody's going to load up again. So again, it's not going to be a losing battle. You're basically emptying a bucket that's starting to overflow before it actually manifests pathologies. So maintenance programs for these EBU programs and even plasmapheresis are basically where integrative practitioners would come into the picture. So I think, though it is an income generation for them practitioners, but if you would see, there is a benefit for this in maintaining somebody's health overall.
Yeah, I think that's pretty neat, actually. Very cool. Thank you.
There's a question about when suggesting glutathione, what route and dose do you recommend?
Yeah. So there's a lot of discussion whether it needs to be liposomal or it should be IV or it should be oral, reduced, etc. When I really scrubbed the literature way back when, reduced and liposomal overall, the levels raised about the same, and the liposomal is much more expensive. However, the liposomal did get intracellularly across the phospholipid membrane better. So if you have someone that's acutely ill, really low, you might use that at the beginning, and then you could switch to reduced. Reduced, however, is water soluble, so you have to do multiple times per day, but it is a lot more cost effective. That's what I found. IV I use only rarely and as needed. Okay. It's very short-lived, expensive.
About N-acetylcysteine then as a precursor?
N-acetylcysteine, great precursor for glutathione. Unless you have all of those glutathione SNPs, you can't even convert it. So I have tendency to just jump to glutathione if I'm needing it and don't know. Yeah.
Okay. I'm gonna go out there. Which I'm sure you have some favorite genetic testing.
I've used several over the years. My favorite of late is Intellects because of their references and their support tool. It's much more comprehensive, and all of their assay testing. If you ask them to give info on how they test, a lot of companies are using very antiquated testing, so you're not getting full RS codes, full reads. They're using the more up-to-date, and they keep staying up on it. So a little more expensive for my patients, but definitely I think a better test overall.
Well, I guess
I'm married to them. That's my personal preference. Yeah.
I guess I could have guessed that, but just was curious. That's all.
That's good. Okay. I like it because it also gives you category A, category B references and suggestions. So you don't have to know all the genomics. You can just say, oh, looks like this has been approved for that. It looks like pignosol can actually be used for this, or maybe I should check a fibrinogen based on this. So I like that.
Wow. It's so amazing.
Right? It's fascinating.
I mean, I feel like the mainstream medicine, they don't do all these things that are so important, the certification and everything. This Dr. Chosky, he told us for fatty liver, he's using mitochondrial peptides, he said. And I think
I also am using those a little bit now. I have a hard time finding really reliable sources in peptides and bioregulatory peptides. My United Kingdom peptide source keeps having trouble getting, things I'm looking for, or they're out of stock, or they're being used for clinical trial phase 2, and now they're gone. So I really have a hard time finding good quality, dependable products. That's my challenge with the peptide world.
Another question. We don't. I didn't get a CME accreditation for this yet, so we'll go with this. Is there a particular brand and dose of glutathione you recommend? Frequency and length of treatment?
It depends on what I'm treating. If they have all of those glutathione-based SNPs, it's a lifetime thing. I do use a lot of pure encapsulations. When we were doing IRB processes for the research studies at Cleveland Clinic, they always passed. Several other companies did, some things passed, some things didn't. They may have metals or they may have not the milligrams it said on the bottle. Like there's a lot of variables, but that one always seemed to come to the top. So I tend to lean on pure encapsulations mostly for my glutathione, especially.
Okay, good.
And just dose and frequency. If
Oh,
you
sorry. Yeah, so it depends on what you're doing, but for a general maintenance, not treatment, it's 100 to 200 milligrams per day. Like if they have a bunch of SNPs and they need some glutathione, and you can check red blood cell glutathione at commercial labs, by the way. So you want to keep them in high normal ranges. But yeah, 100 to 200 milligrams maintenance. If you're treating and you push someone on 500, I hear 1,000, 800, 700, 1,500, you're actually now detoxing. You're pushing them into clean up, clean house. So just be ready for, hey, doctor, I don't feel so good, all that stuff. So
Yeah. Way back when, I think it was Dr. Perlmutter was prescribing 2,000 milligrams to 3,000, like third day for Parkinson's disease.
Yeah, IV especially, he was really, and it was awesome. I have seen the same thing. We use 1,500 to 3,000 here in the clinic for a lot of your neurodegenerative presentations, and they get their toxic screen or toxic test bass, and they're really high, and we're trying to get them better quickly. I will try at least one time to see if they improve while I'm waiting on like their genomics and things like that to come back.
Early on, I had one patient and he was doing great. I mean, he was, he went from rigid and pretty much non-functional to almost back to normal. And then one day I missed the vein and it infiltrated. And then I never saw, he said I heard him and I never saw him again. So,
oh no.
yeah.
But you can do IM too. It just burns like fire. I don't know that I would ever do that, but you can.
That's what this guy. So anyway, yeah, he was coming like twice a week, and yeah, we were giving.
He was probably a poor detoxifier, and they respond really well to that glutathione. It's pretty neat, actually.
He did
Not all of them do, but yeah.
And he never came back, so I don't know. Guess he stiffened up. Dr. Nario, any words of wisdom that coming from the integrative medicine fellowship on this topic?
Yeah, so with detox, we talk a lot about this environmental toxicants, as we call it, and it is really playing a big role here. And it was even emphasized by the fellowship that there's not much training being done here in residencies and even in medical school. And that's why the fellowship kind of gave us a good, thorough discussion about this. And when the one big thing we have to always remember that when we start to look at toxins or heavy metals, we always need to look at fat cells, as mentioned by Dr. Aunna, that adipose tissue stores these specific lead, even plastics that we have. And when we detoxify, even lose weight, especially with the onset of GLP-1s now in our protocols and even in the programs of integrated practices, weight loss will start to detoxify these patients. And that's why even in this setup that our objective is to lower sugar and lose weight, we always have to get ready for getting phase 1, phase 2, phase 3 detoxification pathways all set up when these things happen. And that's why this is something that regular endocrinologists or practitioners doesn't see. But as you see, we could emphasize the specific approaches of integrated practitioners. We have to be 2-3 steps ahead of the game in order for us to anticipate these specific issues. So yes, definitely, we're just not looking at metals by itself, but we need to look into detoxification, and especially now losing weight is one of the bigger things, and how it plays a big role in this whole holistic health that we want to give to our patients.
Okay, Dr. Pigeon, you have your hand up.
Oh yeah, just oops, I don't want the echo. Aunna, I listened to your migraine lecture in Utah, and it was really great. And I was, really interested because I have a patient who has vertiginous migraines for the last 3 years, and I can relate because I've had them myself, and it's life debilitating. Thankfully, I don't have them anymore, but she's not someone that can afford all this extensive testing. So I'm trying to think of the best next steps for her. I mean, she's being treated through neurology, and of course, she's on, Emgaldi now. I think that's how you pronounce it now. Uh, Timoptic eye drops, Inderal, nortriptyline. She's on the CoQ10, the B's, the magnesium. So I'm just trying to think like the next best step. And what I was talking to her about is one thing is her reverse T3 to T3 ratio is very low. That's one thing to maybe think about trying T3, just a touch. But or I was talking to her the other day about the glutathione, but then I'm doing all this research and I'm seeing studies that do show that migraineurs do and show low glutathione. But there wasn't a lot of research to support me starting her on that.
You could do a red blood cell glutathione, but one of the things I would suggest, and you've probably already done it, but go back through her
Hold on,
entire timeline.
you're muted for some reason. Oh, here we go. Okay.
Yeah, one of my suggestions, one, you could try glutathione or you could test it. You could do a LabCorp red blood cell glutathione, or you could, and you probably already done this, but if you haven't, go back through, even if you've done it before, go back through her timeline and listen for a trigger or a moment that clues you. Was it, menopause? Was it a stressful divorce? Was it
right? She's 9 years postmenopause, and the only traumatic event she could say was her dad got really sick about 2 years ago, and she was traveling back and forth to take care of him, but he's since passed. It's been over a year. So
no new change, no environmental change, no new house, no new anything like. Okay, so then you work your way out of all that business, and then I would say, yeah, I would try the glutathione. I would definitely top off the thyroid, because remember, if she's I didn't say that. If she's a DIO2 SNP, that means she can't transport it across blood-brain barrier. So if her T3 is low normal, but she doesn't have a lot available to the central nervous system, more prone to headaches, more prone to migraines, brain fog, etc. So just trying a gentle push. Now, if her reverse T3 is high, though, and you don't give her adrenal support or endocrine support, overall systemic fight or flight support, 3 days into that T3 boost, feeling great, lovely, all this energy, the parking brake's going to slam on, and she's going to be like, oh, it's not working, and I was feeling good, and now I'm really tired. So make sure you're doing some adrenal support of some sort. But yeah, I would definitely say
just adaptogens or any particular adrenal support.
No, just adaptogens. Pregnenolone if she's low on pregnenolone, or progesterone.
She's actually on. I put her on some progesterone. I did trial the hormone route, and she got wigged out by the estradiol, but she's staying on the progesterone.
Good, good. Yeah, that would be a good first step.
Okay.
I wouldn't be afraid to try the glutathione, just considering even the med she's on.
Yeah. Okay. Yeah. All right. Thank you so much.
You're welcome. Thanks for listening. Okay. It's probably late for some of you guys.
Yep. Okay. Anybody else have any comments or questions?
With ASEA water, they said that it increases intracellular glutathione to 600%.
Yes, exactly. And the challenge with reduced glutathione is only that when they did do the studies, it increased mucosal glutathione about 600 times. The challenge was it's water soluble, so they did see that they had to do at least BID doses compared to liposomal. So that was one thing I did find. Yeah. Way cheaper though. And it doesn't taste disgusting. So that's nice. Yeah. All right. Thanks for having me. Thanks for all the good questions and dialogue.
One more combination of CBD and CBG. Reduce of headaches, 200 milligrams of each, depending on severity of the headache. So I'm not sure what's personally what CBG is, but I'm old and I'm still of the reefer madness era. So somebody can enlighten me on what CBG is.
The only thing I know is it increases sleep compared to CBD.
It's the parent cannabinoid of CBD and THC, so that's what's made in the cannabis and hemp plant before it's converted to CBD and THC, and it's non-psychoactive, but it's really good for neuroinflammation, pain and inflammation, that kind of stuff. So,
Got it.
Thank you.
Got it. Okay, thank you, Dr. Herbst, for being here, and especially on such short notice. Usually we say if we enjoy the speaker, especially if they're new, we inflict ourselves on them again. If we don't ask you back, then then we'll leave you alone. So
right. Don't take it personally, but thanks a lot.
Try not to be too overly burdensome. That's Dr. Nario's role.
All good.
This was very enlightening, and I think it was just the right touch. We had our census was down a little bit because, I guess, because of the holiday. So next week we have Piper Dobner is going to be back. She of the fecal transplant fame, and she'll be regaling us with more tales from the GI suite. So we got
more poop stories.
Yeah, we got to run into her a couple of times at A4M, and she was in Reno actually. The night before she was in Reno. I think the night before our conference started, she gave a talk in Reno at a dinner too. So she's pretty interesting. So she'll be on next week, same time, same station, same link. I put in here. I didn't get a CME okay for this week because I think Dr. Halas is somewhere else. I don't know where he is. I haven't been able to pin him down. So in the chat here, if you were at the conference and or online and were a member in good standing, in other words, i.e. you paid, the link for the videos are up. And you can also get your CME credits through the same link, and for the presentations. If you were not at the conference and would like to partake in all that we learned, and you can get 20 CME credits with it. Go to the second level there, the second one down, and click that, and that'll take you through the registration. The first one, you should have gotten an email with the password on it. If you can't find it, contact me and I'll get it to you. We're not going to give it out because we want to make sure we want to honor the fact that you were with us in spirit, and you sort of kept us in Alpo also. So we are actually starting to look at another conference. Probably at the end of May, beginning of June, or maybe the end of June. I have to check the schedule, see where the big conferences are. The A4Ms and the AMMGs and IFM, as I think has theirs also. So we try not to get into too much conflict with them. So remember, we're a small group, but we're feisty, and we had great reviews. We had great speakers, and we had a lot of the folks that you see at the big conferences. So check it out again, congressofmedicalexcellence.com. The agenda is still there and whatnot if you're interested in seeing what went on. You missed the after hours shows. That was they were really fun, and you missed all the food because we fed everybody to the max. And with organic stuff too, which was kind of a bonus. So
no plastics, Dr. Aunna.
No plastics, except for the flatware. But no plastics in the food. So again, if you were there, thank you so much. If you participated, double thank you so much. There are the links there in the chat for the. If you were there, the first one. If you weren't there, $199, get 20 AMA CME credits. And if you need them, especially by the end of the year, the credits are good for a year, by the way. So next December, good for next year. It'll be good for next year. They're good for the homeopathic word also. The link is it's up a little bit here. Let me copy it and paste it again. Somebody said they don't see it, so here it is. And here they are again. Okay. You can get on there on the if you go to the website, there's links for both also. Okay, Dr. Aunna, thank you so much. And I have a feeling we'll be reaching out and twisting your arm to come back in the not too distant future. Next week, Piper Dobner. Everybody have a great holiday, whatever your holiday is. And if it's no holiday, that's okay too. I will be volunteering at a mission on Christmas Day. So that's my contribution. So
brownie points for you.
Yeah, brownie point. So that and I had nothing else to do. So it was either that or lose money at the casino.
Hey, build it up a little bit.
Yeah, Joel is the influence there, on that. So no, I'm happy to do it. So okay, everybody, have a great whatever holiday or no holiday. We'll be around next week again, same time, same station, and again, go to the website if you didn't get the links here on the chat. Thank you all for everything and a great year we've had. All of the videos are on aosrd.org. Most of the videos are on YouTube, except the ones that got banned. Oh, by the way, I muted out, so you don't notice, Dr. Aunna. A couple of weeks ago, Stefan, who was on before, he was on with his mother. He's trained her. She does one-arm pull-ups, and she gave us, and they were doing all sorts of organic things. He was born in Germany, 30, 40 years ago. And she mentioned the Gerson diet, and YouTube banned the video because all she said was that I tried the Gerson diet. That's all she said, and they banned the video for that. So I appealed it. They said no, that's misinformation. I mean, she didn't even say it was. All she said was the Gerson diet, and she tried it for a little while. So anyway, I muted it out. I figured out how to mute it out, and now it's on. So it's on YouTube. 25 minutes and 48 seconds. It's muted out. So to get by the YouTube gods.
You did good.
So it's on there. Okay.
YouTube AI maybe.
Stefan, you put it on. I had it on Vimeo. Put it on
Spotify is cool with it,
but it's on our YouTube channel now, and it's on the AOSRD. So it's just muted out where Mom mentions the Gerson diet. That's ridiculous to me. John, you got anything?
Man, just appreciate the show. Thank you. Merry Christmas.
Okay. Yep. Great holiday season for everybody.
Merry Christmas. Happy holidays.
Yeah. Dr. Nario, thank you for all your help this year. I couldn't have done it could have done it without you, but I'd rather not. So, and especially the regulars that are here every week. Thank you all for participating. And we've been doing this now since October 2020. We've been doing this for 5 years running now. And,
hey, we do good things. That's why we're still here.
Things, and we'll see which authorities and licensing entities will come down on us next.
Don't be asking for that.
Badge of honor. Okay, everybody. Thank you so much, Dr. Aunna. I'll send you the video when it's ready, and I'll send you the participant list also. Okay?
Thank you.
Bye.
Bye.
Bye.